Hello all, this is Dr. Kaustubh Mohite, your pediatric pulmonologist. And today we'll be talking about some basic respiratory physiology, that is hypoxia and types of hypoxia. So before we start, it is really necessary to differentiate between hypoxemia and hypoxia. So what is hypoxemia? It is low levels of oxygen in the blood. So that means low blood oxygen concentration. Whereas hypoxia is inadequate oxygen at the tissue level. Usually, hypoxemia leads to hypoxia. However, this is not always true. Talking about hypoxia, as I've already said, hypoxemia is the most common cause of hypoxia, even though it is not the only cause of hypoxia. Because there are cases in which you can see hypoxemia without hypoxia, as in patients with compensated for low PaO2 by increased oxygen delivery, that is by increasing the cardiac output. Whereas there are conditions in which you can see hypoxia without hypoxemia. That is in cases in which oxygen delivery to the tissue is impaired or the tissue is not able to extract oxygen effectively from blood. So based on where there is pathology, we divide hypoxia into various types. That is hypoxic, stagnant or circulatory, anemic, histotoxic, and there's a new terminology called oxygen affinity hypoxia. So first, talking about hypoxic hypoxia, which is also known as hypoxemic or arterial hypoxia. This results mainly from insufficiency of oxygen available to the lung or decreased oxygen tension. So it is majorly characterized by low arterial pressure of oxygen, low arterial oxygen content, low arterial percentage of oxygen saturation of hemoglobin, whereas decreased difference between the arterial to the venous partial pressure of oxygen. So the mechanism of decreased PaO2 can be because of a ventilation by perfusion mismatch in the lung, causing a widened alveolar to arterial gradient, and these are the cases in which oxygen therapy will be actually effective, or it could be because of increased pulmonary shunt, that is perfusion without the gas being actually exchanged. And these are the cases in which oxygen is actually of no use. The causes can be mainly divided into cases in which there is low oxygen tension in inspired air, as in high altitude or breathing echo spaces, in respiratory disorders with decreased pulmonary ventilation, as in asthma, pneumothorax, sleep apnea, or any neurological condition, respiratory disorders associated with inadequate oxygenation of blood, like in pneumonia, fibrosis, emphysema, pulmonary hemorrhage, or bronchiectasis, or finally, cardiac disorders in which there is congestive heart failure or low cardiac output. Next, coming to anemic hypoxia. This hypoxia is mainly because of decreased in the amount of hemoglobin, which decreases the oxygen carrying capacity of the blood. It is caused mainly because of decrease in the number of RBCs, decrease in the hemoglobin content, formation of altered hemoglobin, or when hemoglobin is combined with any other gases than oxygen or carbon dioxide. Talking about stagnant or circulatory hypoxia, it is also known as ischemic hypoxia. It is a condition in which the blood flow to the tissue is either low or slow, in spite of arterial PO2 being normal. So the pathophysiology can be divided into either decreased cardiac output, where there is, in cases of cardiogenic shock, where there is extremely low cardiac output, in which it causes decreased mixed venous oxygen tension and does not permit complete oxygenation of the blood during pulmonary gas exchange, or increased non-pulmonary or extrapulmonary shunting, as in cases with hepatic failure like cirrhosis, in which there is release of a lot of endotoxins causing vasodilatation or arterial dilatation, causing bypassing of this blood from the pulmonary circulation. The causes being congestive cardiac failure, hemorrhage, surgical stroke, vasospasm, thrombosis, or embolism. Next comes histotoxic hypoxia, in which there is inability of the tissue to use oxygen even in the absence of hypoxemia. The typical example being cyanide poisoning, in which cyanide interferes with the aerobic cellular metabolism by destroying the oxidative enzymes, which completely paralyzes the cytochrome oxidase system. The next new term which is being coined is called as oxygen affinity hypoxia. It is nothing complicated, but can be very easily understood by this oxygen hemoglobin dissociation curve. Any factor which causes the shift of this curve to the left causes increase in the affinity of hemoglobin towards oxygen, which causes decrease in the supply of oxygen at tissue level. A typical example being carbon monoxide poisoning. So if you summarize, hypoxic hypoxia typically presents with decreased partial pressure of oxygen in arteries, with decreased arterial oxygen content, decreased arterial hemoglobin oxygen saturation, whereas decreased in a difference in the arterial to venous pressures of oxygen. And these are the cases which typically present with cyanosis. Next, anemic hypoxia are the one in which there is decreased hemoglobin count, which causes significant decrease in the arterial oxygen content, causing further decrease in the hemoglobin oxygen saturation. The only clinical way or lab parameter to differentiate stagnant or histotoxic hypoxia is to find out the difference in the arterial to venous partial pressure of oxygen. Since there is decrease of blood reaching the tissue at stagnant hypoxia, there is more than normal of the difference between arterial to venous partial pressure of oxygen as compared to histotoxic hypoxia, in which there is decreased than normal. That means that there is decrease of oxygen being taken up by the tissues itself. I hope this short session was helpful for you, and I'll be coming up with more of these simple respiratory physiology chapters in the coming sessions. Thank you.